Welcome, everyone. Thank you for joining us today. My name is Rosalie Wanch. I'm a senior policy analyst here at the C.D. Howe Institute. My colleagues and I are glad to welcome you to this event and want to thank you for your support of the Institute. Our members, the foundation of our mission is really to foster smart economic policies. And when we're in a situation where we have millions of Canadians without a primary care provider, I think it's just about the perfect time to discuss the nuances and complexities around expanding scopes of practice and improving access to care. I will not be alone today in talking to you about this, and I will leave it to our sponsor for today's event. And thank you to Johnson & Johnson. Geneviève Lavertu, the head of, I was gonna say, head of government affairs and policy or government relations at Johnson & Johnson, to actually introduce our esteemed panel. But really, I would just like to say that these events would not be possible without the support of our members and as well, particularly our sponsors. So if there's something that there's a really, an issue you really want to talk about, we're happy to bring the group together, and especially with an online format, make it as convenient as possible for people across the country. And so without further ado, I will welcome Geneviève to introduce our panel.
Thank you, Rosalie. So I'll give you a hand. I'm Director of Government Affairs and Policy for Johnson & Johnson MedTech in Canada. And it's my pleasure to be able to offer this forum in honor of the C.D. Howe Institute's commitment to quality, independence, and nonpartisanship, to talk about really pressing issues with courage and clarity, and with the full display of the variety of opinions that can exist. I was very encouraged by some of the stupendous work that C.D. Howe has done, and how the changing landscape of our healthcare delivery can be anticipated. And one of those was the paper that was published on the scope and nature of private healthcare in Canada earlier this year, which also addressed the question of changing roles for healthcare professionals. And why Johnson & Johnson was very interested in furthering the conversation is because it does affect how all of us work in the landscape of healthcare in Canada, as the stakeholders are changing a little bit differently. Providing care is coming in different forms. We are also interested in seeing how roles are changing around the policy questions of value-based healthcare, for instance, that really put a premium on multidisciplinary teams that really allow healthcare professionals to use the full breadth of what they have been trained for, and create better care pathways for patients around an entire condition, for instance, like C-section care or other types of similar interventions. So we want to think together with you about what that might look like. And we're delighted to be able to hear from our panelists today. I will start with Michelle Acorn. Dr. Acorn has over 35 years of nursing, health systems, and leadership expertise. She is a nurse practitioner, and she transitioned to her NPAO CEO role in January 2024. So congratulations. And she was previously the inaugural chief nurse with the International Council of Nurses, a former provincial chief nursing officer of Ontario, and has served as the NPAO president. As our second panelist, we will also have Mr. Justin Bates, CEO of the Ontario Pharmacists Association. Justin was appointed CEO of OPA in September of 2019, having previously served as the CEO of the Neighbourhood Pharmacy Association of Canada. Justin is an executive with over 23 years of experience in the financial services and pharmacy industries, with an exceptional record of relationship management and producing value-driven sustainable solutions for clients. And lastly, but not least, and you'll notice this was in alphabetical order as well, we have Mr. John Richards, who is an emeritus economics professor in the SFU Public Policy School and a CD Howe Fellow in Residence. Recently, he published an e-brief analyzing the multiple causes of the present primary care crisis. Relevant to this panel, he has 3 decades of experience as a director of the nonprofit Mid-Main Community Clinic in East Vancouver. So without further ado, I will give the floor to Mrs. Dr. Acorn.
Thank you so much. Pleasure to be here today, and thank you for the kind opportunity. I'd like to just add also the context as I remain a clinician and I still practice on top of holding my executive leadership roles and am a professor. Here's the stark reality. The number of people without a primary care professional continue to increase, leaving millions lacking access to care in a healthcare system that's struggling to cope with the overwhelming demand. At a time when there's a critical shortage of primary care providers, nurse practitioners present a key opportunity to close the gap and connect Ontarians, Canadians with care as well. We know there's many proven benefits and outcomes of improved integration with nurse practitioners. They're one of the most highly researched practitioners that are safe, effective, and efficient, and they can actually transcend and be integrated across the healthcare system. For many patients, working with a nurse practitioner means they can access care quicker and closer to home. Wait times, emergency visits, hospital admissions, and readmissions are also reduced, alleviating some of the most significant pressures on our healthcare system. We're working hard to ensure that we can practice to full scope and are appropriately compensated. Currently, the lack of flexible funding models limits the number of public positions, preventing them from practicing to full scope of practice where they're needed most. We need to support the education, training, retention, and integration of nurse practitioners across a publicly funded healthcare system where they can deliver high quality, timely, and life-saving care. Without this accessible funding and a seat at the table with nurse practitioners, they're key for ensuring Ontarians have access across Canada as well. I think with the recent appointment with Dr. Jane Philpott to the chair for the new primary care action team, it sends some recognition early, signaling that she mentions nurse practitioners are another important acknowledgement of the role NPs play as critical providers of comprehensive care and ongoing care and leaders in primary, secondary, and tertiary healthcare as well. Here are the numbers. There's over 5,300 nurse practitioners across Ontario, over 10,000 across Canada. According to CIH data, right now there's over a 10% oversupply. As a result of this, we have those that are underemployed, unemployed, or not fully utilized to the top of their scope of practice. So right now, we're ready to support healthcare across Ontario and Canada right now, and they can recognize their contributions across primary and care beyond addressing the gaps. We know it's a health workforce tsunami right now, and we need to think about, do you know what a registered nurse is? And not just as a clinician and a leader. A registered nurse, that's how we begin our career. We complete Bachelor of Science education and many, many clinical hours and write an examination. Thereafter, you need years of experience, at least 3, to become a nurse practitioner, which is title protected. On average, in Ontario, nurse practitioners have 10 years of experience, 10 up to 20 years of experience as well. And what's happening on the regulation landscape is really important for scope of practice as well, because there's going to be a 1 nurse practitioner exam and regulation across Canada, which will facilitate portability and nimbleness across all the provinces and territories as well as we modernize. When we talk about scope of practice, I think we need to talk about controlled acts and what that looks like as well. Nurse practitioners can assess, diagnose, treat common conditions, chronic conditions, some specialize as well. They can do palliative care. They can admit, treat, and discharge from hospitals. They're attending nurse practitioners, for example, in long-term care. They're integrated across primary care. There's over 27 nurse practitioner-led clinics, by the way. The research shows astounding support, public confidence in that. And I think we need to really think about the information of dedication, data, dialogue, and decision-making for dissemination. We know they have the knowledge, skill, and judgment. They have the thought leadership to be not just clinicians, but at the decision-making tables right now. They work in team-based care right now, and they're easily accessible solution, not just in the short term, but the long term, so that you can have access to a primary care provider and you're utilizing people to the top of their scope. There is also a significant challenge. We'd say, for example, 2.5 million people, 2.3 million people in Ontario do not have access to a primary care physician. The realities are they don't have access to a primary care provider. Nurse practitioner data is not collected due to attachment at this point in time. And if we're going to continue to evolve and notice the impact and measure the impact of nurse practitioner practice, we need attachment data, everything from prescribing, looking at the primary and secondary prevention efforts as well, and having a seat at the decision-making tables and governance. I think it's really key as well that we really talk about positive practice environments and how we respect and recognize the health workforce specifically, to ensure that they are feeling appreciated, respected, and recognized as well. I think later, depending on our time we have, we really also need to define what scope of practice is and how it is really evolving locally, regionally, nationally, and globally as well, because it's varied across formal and informal practices and sectors, as I mentioned. The scope of practice refers to licensed activities, and it's authorized or permitted to be performed based on professional knowledge, skill, and judgment and expertise. We tend to think about that just clinical piece. And it can be controlled or managed or enabled or minimized by organizations or employers to restrict or enable and empower efforts as well. So that significance of scope of practice is not just translational or transactional, I guess the word would be. It's not about task or scope based. It's actually about transformation, and how do we know that we're making a difference? We're working to that top of our scope, and we are thinking about their recruitment and retention and value base that's wrapped around the optimal outcomes for our patients. I'll stop there. Over to my colleagues.
Thank you so much. I think there was a lot of good points there, and we covered a lot of ground, everything from how much care is actually being delivered to labor supply and demand to recognition and retention. And I think that all of those are important. And we'll mention this now, and I'll mention it again when we get to the end of the remarks. But I would just point out to participants that if you would like to ask a question, you can put it in the Q&A box, which there should be a little pop-up window at the bottom right of your screen. And so we will save questions until the end after all of the panel presentations, but please feel free to add them as we go, so that you're at the top of the list when we get to the end of the presentations. And so up next, we've got Justin.
Thank you, Rosalie, and thank you, Dr. Acorn. I think that was a great way to start the session off and tee up some of the hot topics that I think are germane to all healthcare providers and contributors to the healthcare system in Ontario and, of course, across the country. A little bit about the Ontario Pharmacists Association. We are a not-for-profit advocacy organization serving well in excess of 10,000 pharmacy professionals and pharmacies. So that's a bit of a distinction. About 60% of pharmacies in the province of Ontario are independently owned by a pharmacist. And then, of course, there are larger corporations that have a grandfathered in charter that allows them to operate pharmacies. So it's a very diverse environment that we operate in. There's about 22,000 pharmacy professionals. That includes student interns, pharmacy technicians that are regulated by the college, and pharmacists that practice in a variety of healthcare settings, including hospital pharmacists, pharmacists that practice in long-term care homes and residences that serve their patients there. And of course, in community practice through pharmacies, and there's about 5,000 pharmacies across the province. And I think that's important as we look at also some of the economic contributions when we advocate about Main Street, small business, as well as healthcare providers. We look at some of the strong data that supports the sector, from manufacturing of drugs through distribution, wholesale, to the pharmacy and pharmacy professional relationship with the patient, and generating over 6.3 billion in economic output in Ontario. And one of the data points that I think is really important to emphasize, and it underscores the importance of unlocking the value of pharmacists in providing a holistic approach to looking after their patients through their journey of health and healthcare needs, is that on average, a patient sees a pharmacist 12 times more annually than they do their primary care physician. And as Dr. Acorn mentioned in her opening remarks, that that assumes you have a primary care physician, and we know that there's a significant gap in care and access for Ontarians, somewhere in the neighborhood of 2.5 million Ontario residents that don't have a primary care physician. And I think we're at the precipice of a lot of change, transformation, innovation, and people are scared. People are needing care, and we're emerging from a pandemic where many people didn't get their routine vaccinations. They didn't get the healthcare screening that they typically would. And I think the biggest cost to the system, both from a private payer perspective as well as public, is going to be the unmanaged chronic disease. And that's where pharmacists can play a much greater role. And we see the current government in Ontario really leaning into scope of practice across all healthcare providers. And I think that's really important because a lot of the advocacy we do, whether it's through the media, direct lobbying to government, and working with all stakeholders, is the fact that there's not one solution, or this is not going to be a panacea by expanding scope of practice. There needs to be long-term, beyond political budget cycles, investments in our healthcare system, from institutional care in the hospital side, as well as in the community where people are accessing care more conveniently. And that needs all healthcare providers, not just pharmacists, but indeed all midwives, nurses, paramedics, to be able to have scope of practice that aligns with their education, competency, and not only their foundational education, which in the case of pharmacists are many are now PharmDs, so a doctorate of pharmacy, and they have 6 years advanced training above and beyond their undergraduate degrees. And in most jurisdictions in Ontario, or in Canada rather, pharmacists are far outpacing in scope of practice. I mean, Alberta has been the high watermark for pharmacists in terms of prescribing authority. They are autonomous prescribers and have been doing that for 15 years. So when we think about the Ontario example, and we look at the recent scope regulations, consultations to expand the minor ailments program and give Ontarians more access and choice, and we think of some of the reactions of some stakeholders, it's interesting to watch because we have a lot of data that supports the safety and the competency and effectiveness of pharmacy-based services. And team-based care is really important, collaborative care, interprofessional care, and we do need the infrastructure, IT, electronic health records, to be able to enable a lot of this in a more efficient way. But that said, when we look at where we see the opportunities, is pharmacies are like a healthcare hub. They're in communities, small, big, large, rural, remote. They serve marginalized communities, and there's a trusted relationship with the pharmacist. And we know it works because the other jurisdictions have been doing it for several years in a most safe way. And we can actually show through independent research that an investment of $2 in pharmacy, actually, sorry, an investment of $1 generates $2 of savings in the overall healthcare system. But one of the challenges in the team-based approach is that we need that infrastructure to be able to readily share information. Electronic automation, digital health is a big component of that, but it shouldn't stop progress around scope of practice. We need the investments in the e-health infrastructure to keep pace. And there are multiple models of care. So whether you're talking to a physician, talking to a nurse, and it's a nurse-led, a practitioner-led clinic, or a pharmacist-led clinic that we see in many parts of the country, including parts out east in Nova Scotia, where they can do a lot of prescribing. And it's not initiating new therapies for a new diagnosis, but it is where you have diagnostic testing and you confirming a diagnosis, you can initiate new therapies. And that's been really critical in the Nova Scotia experiment, to be able to get to a place where people are getting care faster, whether it's trying to look at acute conditions like strep, the diagnostic testing there and the accuracy of it to be able to get somebody on a antibiotic quickly, or looking at things like diabetes management, hypertension, lots of things to save the system downstream and avoid people creating that burden on the healthcare system and emergency departments. But we still need to hire more family physicians. We still need to continue to invest in a sustainable, financially sustainable system. So the respect to pay for what the scope is really important as it relates to pharmacists and nurses and other parts of the system. We can't just give them scope of practice. We need to make sure that we're supporting the professions from both the financial perspective, but also from mental health, ensuring that there's that level of autonomy for our professionals to practice the way that they need to serve their patients and to drive better health outcomes. And that autonomy comes to, for us, also important for patients. We want to make sure that patients have choice, and that they can maintain the relationship they have with their healthcare provider and not be forced into arrangements that aren't necessarily in their best interest from a clinical or healthcare perspective. So much we can do in terms of moving forward together. And I think that's the underlying message that I always have, is that we need to continue to work together with all healthcare providers. It's going to take all of us to create capacity in the healthcare system and identify the gaps and help close them. And we can do that in different models of care, and working with our physician colleagues and really transforming and redefining what primary care means, because primary care doesn't necessarily have to be controlled and run by a family physician. That's one model, but nurses and pharmacists can also manage patients, and that's within their competency. It's within their current training. And new scope goes through our regulatory process and oversight with our college, and the continuing education supports that rollout to make sure that we're operationalizing and delivering the services in the community through our pharmacies in the most effective way, and managing both the demand and the workforce challenges that come with that, in terms of making sure we have the appropriate labor pool, we have the appropriate appointment-based modeling in pharmacy to manage things like vaccinations, which we saw through COVID, where there was such a high demand, almost a Hunger Games kind of scenario, people looking for COVID vaccines, and we were able to quickly mobilize across the country, and in particular in Ontario, to ensure that people had access to their vaccinations. And we need to start looking at that and saying, if I have a patient coming into a trusted healthcare provider like a pharmacist for one vaccine, why wouldn't we offer all the vaccines, all publicly funded vaccines? It just makes sense because we have the captive audience and the patient there to be able to look after all of their needs. But in Ontario, we're taking a bit of an incremental approach in terms of we do a little bit of scope and then we stop, and we do a little bit of scope and we're still playing catch up to where pharmacists are in other parts of the country. And there's really no difference in the education, whether you are educated in BC, Alberta, or Ontario. And the reality is the patients and their needs aren't that different from one postal code to the other. So that's one thing that we want to make sure there's more harmonization with the mobility of patients and pharmacists to be able to harmonize across the country. What that scope of practice looks like, we think makes a lot of sense. Not sure how I'm doing for time, so I'm just doing a quick check.
Well, I was gonna say, I think you're at time, but you also ended on what I think might be kind of a perfect segue to John, but we've added some dimensions to the conversation. I think particularly, I've heard the word harmonization. There was also some discussion of national licensure. You didn't go quite that far on pharmacists, but I think this idea around harmonization, or at least the linkages, to ensure that as different scopes expand, that sort of all the providers involved in a particular patient's care journey have access to the information they need, and making sure that those records are up to date for any point where they may be entering the system. And so our final panelist is Professor John Richards, who I've had the privilege of working on a number of various research projects with. I'm sure we've debated a certain amount, and really we've had discussions about how expanding scopes can work actually in a couple of different structures and ways of delivering primary care. And so I'll turn it over to John, and maybe I'll add my own points and moderator privilege when we get to the Q&A. I'll resist. It's very difficult, but I'll let John go first.
Thank you. As a prof, ex-prof, emeritus prof, I'm used to having at least an hour. 8 minutes is very painful to discuss only for 8 minutes. I am part of the fag end of the cohort in Saskatchewan that in the 1960s and 1970s made the major moves towards universal health insurance. And it's something that we in Saskatchewan, well, I'm not in Saskatchewan, now I'm in Vancouver, but I psychologically still belong in Saskatchewan. It was our major contribution to making a good social policy network in Canada. And professors are always good at reading books and being boring. I do have some practical experience in actually managing healthcare. So Saskatoon, town of about 300,000, had one of the largest multidiscipline nonprofit community clinics. And interesting, perhaps for you, Justin, I mean, we made a major role in pharmacy policy in Saskatchewan. We, of course, had a pharmacist. What respectable community clinic would have just doctors? We had a very powerful, good pharmacist in charge who not only advised the doctors in our clinic what they should and shouldn't do in terms of prescribing, and also turned to the provincial capital and the health ministry said, look, you should do this and you should do that. And our pharmacist in that clinic was probably the chief expert on pharmacy policy in the entire province. And he had actually a reputation beyond that. And I've been involved as a director in multidiscipline clinics for 40 years. I guess I'm embarrassed to admit how long that is. We've just set up a new clinic in East Vancouver. It cost us one hell of a lot of money. But we made sure that there was space for 2 young, bright pharmacists who were part of the team. And we would just be silly not to use the professional expertise of pharmacists. Now, what is controversial in what I'm arguing is that the crisis which is upon us, and it is a crisis. I mean, one of the simple ways of thinking about this, OECD, big organization in Paris that publishes every 2 years health glance. And there's a large amount of useful data. One of the pieces of data they do is a survey of patient satisfaction. And we were fine up to about 2019 in Canada in the sense that we were above the OECD average. And we collapsed. And the last time this has been published by the OECD was in 2021. And we lost about 20 points. We went from high 70% satisfaction down to 55, 56%. And this was a huge collapse in faith among Canadians in the present situation. Now, I mean, I can go on for the hour if you let me, but probably you shouldn't. I did this monograph motivated partly by our traditions back in Saskatchewan, partly trying to understand why things went so bad after COVID. There are many problems. One of them, and that's controversial, physicians have too much influence, and provincial health ministries don't have enough ability to think through institutional reforms that should be done. Just to keep things simple, the monograph that I wrote, and I'd be delighted if people taking part in this web read it, criticize it, and I'll certainly get back to them. So I emphasize two things. One is the need to free nurse practitioners from GPs, and that hasn't been done. All of the various complicated multidiscipline primary care situations have been dominated by physicians, thinking of nurse practitioners as juniors, not really equivalents. That has to change. And part of the problem is it is very politically attractive to have a new hospital, which is going to train physicians. Fair enough. My university is going to have a new medical college, very expensive. And by 2030, hopefully there will be more physicians. But we're doing very little in British Columbia in the promotion of nurse practitioners in community contexts of multidiscipline primary care. Ontario is the best in the country. I'm not saying it's perfect, far from it. But roughly half the nurse practitioners in Canada are in Ontario. And the attempts to try and integrate nurse practitioners with physicians and pharmacists and other important people in the context of primary care has not existed in most of the provinces. The physicians have stayed on top, and they have done a lot of the public policy in the last decade. Some of it is perfectly good, but there's an obvious self-interest not to expand nurse practitioners to the extent that they should be expanded. The problem is not scope of practice. In virtually every province, a nurse practitioner can, in principle, do most of the activities that a GP can do. And there's lots of academic randomized controlled trials, patient satisfaction on GPs versus nurse practitioners. And usually the nurse practitioners come out as well, if not better, than a GP in terms of patient satisfaction. I could go on this, but I obviously want others to get into this discussion. So I'll stop right there. There's a lot to be said. It's a very complicated subject, and I'm delighted to be part of the discussion.
Well, I will say thank you, John, for your remarks, as well as the rest of our panel. I believe our events team is going to put up some instructions for how to get your question in the Q&A in the little pop-up box. I think, you know, between Zoom, Teams, and WebEx, actually getting all of them to work exactly as advertised on any given day, kind of, I don't want to say it's a microcosm of our technological linkages in the healthcare system. That might be a little bit mean to the various tech companies, but it certainly is always always an adventure every single time you switch platforms. And one of the things that I wanted to maybe reference, since John talked about the OECD, is that I've been tracking the internal Canadian polling data around both the large issues as well as just the healthcare polls. And I mean, for a couple of years during the pandemic, the healthcare was the top issue for Canadians. But it's kind of fallen back to that third issue. It's kind of always in third. It never drops below fifth. But when you look at the health specific polls, not only are we continuing to decline since those 2021 numbers, we've had a significant drop even in just the last year. But Canadians are losing hope that the system will actually change. But that doesn't cover what actually has been changing. Justin, you mentioned how, you know, scope is expanding at the pharmacy level, and there is the minor ailments program. We do have 27 nurse practitioner-led clinics. But I guess all of these actions around the edges are happening. But as John said, we've known for quite some time that expanding scopes is good for patients, and it can save money and prevent worse health outcomes down the line. So maybe the general question I'd turn to all of you is, what do you see as the biggest roadblock to sort of expanding out? Is it IT? Is it the funding models? Likely the answer is all of the above, but I guess it's sort of like, if I could give you one wish of the thing that you would wish to change, what would it be?
Can I start us
Maybe
off,
it's like go in the
Rosalie?
order. Yeah, it's
Sure.
like Michelle, you go first, Justin,
Fine.
and
Thanks
John.
for
We'll go
that.
in the order.
One ask, and I'm going to limit it to one, is flexible funding models for enhanced integration for nurse practitioners and other healthcare workers right now. If we accelerate rather the creation of multiple funding models, we can facilitate the appropriate integration of nurse practitioners across the healthcare system and within healthcare teams. We practice across almost every medical specialty, and often a lot of extremely specialized care, and the flexible funding models will allow nurse practitioners to serve patients to their full potential, grant them the ability to meet the growing demand for healthcare services right now. And we need to think about how we actually practice and the models of care. Right now, we're dependent on bureaucratic process for investments, expressions of interest right now, perpetuating the same traditional models of care right now that can incentivize or disincentivize team-based care. And we have a health workforce tsunami right now. And if we want to actually encourage and retain people in our workspace, we need to enable and empower them the ways they work. That is scope of practice, and that's funding, whether you wish to be an employee, whether you wish to have a solo practice, or, like our Jason and our pharmacy team joining together. Right now, though, there is no mechanism in place right now for that for nurse practitioners, and hence the Canada Health Act challenges that we're experiencing. These are the crucial conversations. Emotions are high, egos may be high or higher, but the reality is that this is about healthcare right now, and we need to be all on the same team right now because we can be better together.
Well, that's a tough act to follow. I could say all of the above, and echoing some of those sentiments for sure. I mean, I've learned a long time ago, everything's about politics and money. So
Yep.
when you follow that, you kind of understand where some of the gaps are and barriers. At the end of the day, the system is set up to be siloed. We have provincial budgets that are essentially divided into each of the silos, whether it's the OHIP budget for hospital care, and then primary care budget, public health, and they're little fiefdoms. And what that does, it's like an organization where you're trying to create that culture of a flat organization and everyone's team-based and working together, but you still have this hierarchical reporting structure. So if you look at it from a healthcare perspective, anytime scope of practice gets announced, what's the first thing we hear from? And who do we hear from? We hear from those that control the money today as a traditional gatekeeper to healthcare, and that's the primary care physicians, right? And I have family docs in my family, and I have great respect for them, and they're part of the solution. But when I see the disparaging commentary, whether it's nurse practitioners, midwives, paramedics who get scope of practice, and now pharmacists, it's the usual fear mongering. The sky is falling. Competency issues, safety issues. It should all go through a family physician. Let's be honest and let's be transparent about that. They have a model of care that is absolutely viable and should be part of the solution. But as John was saying earlier, it's a very much a control. We love pharmacists. We love nurse practitioners. We think they're very competent as long as they work under the control of a family physician. But if they don't work under our control, which they do now under medical directives, so this is not new, even if they don't have the scope. But now all of a sudden, if they're going to get money that we want, because we want that money directed into primary care, rather than raise all the boats, everyone needs the funding, needs to be sustainable. It pits one provider against the other. And that's not a good look. It's not patient centric. So the one ask and the one thing we need to look at is, we need to look at government. There's an ideological challenge in some provinces and some governments. I think clearly we have a government here that's moving on scope, but it took 15 years to do something that another province did already. So you have to work through the politics of that piece. But if my ask is, we got to stop looking at this as providers and about patients. How do patients navigate the system? What's the patients are confused. Even, I mean, the clinic model is brilliant and it works well. And whether it's led by a nurse practitioner, a pharmacist, or a physician, that model, people need that access, but they don't know where to go. The funding model is always a debate in our healthcare system because, you know, we can't say the word private in Canada because it's always a negative connotation. But the reality is we have private delivery of care across the country, always have had it in a publicly funded system. And that's what we need to figure out. It's okay to have private delivery. Family doctors run a business and get paid for it, but it has to be fair, transparent, reasonable funding so that we can respectfully set these clinics up with the right scope to be able to serve patients. And it shouldn't be about taking from one provider and giving to another. Everyone needs to be part of that solution. And I think that's the biggest challenge, right? It's that the money and the politics is what I basically boils down to.
It's like, John, just before you jump in, I wanna just jump in on that just because, you know, the words private and that money and politics rule the world are not necessarily common things to have in a healthcare discussion, but at the end of the day, John and I are economists, and so that's a base assumption for almost our entire discipline, is that politics and money is what kind of decides what happens. But I just wanted to bring out one more OECD point where in Canada, we actually make the word primary care almost synonymous with a family doctor. And I think without sort of changing that thinking, we're having a different conversation. And why I'm bringing this up is actually in those OECD stats, Canada is pretty unique in the number of family practitioners and the number of primary care providers are the same number. Those are two different things for most countries, and in most of the, so much so that the international comparable stats have distinct numbers between what is a family physician and what is primary care. And primary care will include nurse practitioners, pharmacists, dentists, optometrists. Essentially, the broad international definition is first point of contact with the healthcare system. So that could be EMS, or it could be any kind of care. Essentially, where's your entry point, and that is primary because it's your first contact. And it's, you know, it's sort of one of those things where we have a different discussion in Canada about what primary care even means. And I think that partly that's because the public insurance system doesn't include dental, pharma, mental health. And once you include those things in the public system, then it becomes much more obvious how they are related to primary care. So anyway, sorry, just needed to make that one additional point, that I think that you've hit on something important in terms of what we actually consider to be primary care in Canada, and that we've almost made that synonymous with the word physician, which you can do, but that's not how the rest of the world necessarily thinks about it. So yeah, I was like, John, you can get into the political economy stuff if you want, but I just wanted to get to that one culture point.
Is it my turn, Rosalie? You're in charge. Okay, as you can guess, I agree with you that this is a problem. That in Canada, politicians, academics, most people think this is a matter of not enough GPs. And I argue that the physicians' associations have too much influence, and too much of the emphasis in trying to increase care providers is being devoted to more GPs. Obviously, that training is expensive. Obviously, Canadian physicians, I have a great respect for them, for the work they do, albeit there are complicated changes which have brought on this crisis. The changeover of generation, younger physicians, quite legitimately, do not want to work 60, 70 hours a week as some of their older people my age as GPs. There has been a significant decline in hours worked over the last decade. There's been a decline in thereby services per physician. There has not been a comparable emphasis in Canada among health ministries, notable exceptions here and there, to increase dramatically the number of nurse practitioners and to get the NPs, nurse practitioners in Ontario, concerned in doing that. Now, there are obviously some good things going on. Alberta has liberated, so to speak, its nurse practitioners. There's the nurse practitioner clinics can, in principle, now in Alberta they don't need to satisfy the Alberta Physicians Society. I mean, that is and all of us have got that kind of frustration. And certainly, certainly you made it, Justin, a part of your discussion. Pharmacists can play a larger role than they are doing. There are not very many clinics across Canada which are incorporating centrally pharmacists in multidiscipline clinics. And often pharmacists make much better use of pharmaceuticals than do the GPs. Enough from me. I will shut down. I can go on for too long.
I'd love to jump in if you don't mind. Things are actually
please do.
resonating right now. And Justin, you raised a good point earlier. We talked about doctoral level preparation and with expanding scope and competencies from entry level to post-graduation, we have a lot more professionals that are doctors as well. I'm a doctor nurse practitioner. There's PharmDs and things like that. Even if you talk about value and scope, we don't even recognize that, or it's prohibited using the titles in clinical settings and things like that as well. That also, in terms of mental models, is a big consideration. And John, you raise a very valid point. In Alberta and BC, there's different models of care where you can get a bit more direct funding from the government specifically right now, but it doesn't kind of consider some of the age or complexity, and the remuneration is at 80% when it's equal work for equal pay as well, when we talk about scope of practice. And I think that team-based care, we really all need to define what that is, because it's a collaborative effort that empowers healthcare professionals to coordinate their skills and expertise to improve patient outcomes as well. So we really need to think from that health systems approach. And we tend to still get into who's leading the teams right now and some of these different hierarchies and stuff like that. And for us to be able to move forward, like scope of practice consultations, we started from a list-based approach. You know, we now have broad prescribing. We have provincial enablement. We have federal enablement of controlled drugs and substances. And there's even RN prescribing, for example. But again, it's not fully integrated across all the sectors, similar to my esteemed pharmacist colleagues in Ontario may have the Hospital Act, the Public Hospital Act, that may be limiting as well for different things like that. So if we're really going to harmonize, as you brought up earlier, our moderator is right on track. We don't even harmonize, let alone across our provinces and territories in the sectors as well. And it's very laborious when you put something into legislation or regulation or bylaws, because still the government's and leadership and voting powers on these are unequal in terms of professional parity.
Yeah, and I was gonna say we do have some questions that have come in through the chat and the Q&A box. And so maybe I'll start with one. I'm sure almost everyone on this call is aware that today the reason we had to reschedule was because the federal health minister wanted to come and give a talk. And so the question we've got coming in is related to that, and it was essentially what would the role, is there a role, or what would the role be for the federal government, or what tangible reforms would you encourage at the federal level that could encourage this? And I would say the question in the chat is related, but doesn't actually ask about the federal government at all, and is really just, if you think there isn't a specific role for the federal government, what else could be implemented in terms of policy to expand NP-led clinics and the integration of pharmacists in this clinic model? I'd say it seems you've convinced our audience, but maybe we'll start with what should the federal health minister do? And if not the health minister, then who else and what should they do? And John put his hand up, so I'll let you go first.
Okay, if I had to, I would say no. The feds cannot solve this problem. The feds are good at writing checks. They are not good at working out the complex relationships among professionals involved in a healthy system of healthcare. And the same can be implied with respect to education. The provinces have made, I think, though they have been too passive in the last decade, and they have allowed their respective provincial physicians associations to play too large a role. And the provinces have not done what they should in terms of thinking about innovation, which all of us are agreeing is important. But I must admit, I have very limited respect for the ability of the federal government to take this over. There are so many differences from one province to the other, north versus south, and my experience with the feds with respect to social policy was a painful, long exercise trying to improve reserve school systems, and it all came to naught. There is not in Ottawa a sufficient appreciation of the complexity of professionals' roles and thinking that through. So others may disagree.
Well, I think it's a complicated web, right? When you look at jurisdictionally, constitutionally, where the federal government plays a role in health versus the provinces. So you have that constant push-pull, and really two things come to mind. You mentioned about a role of funding. So we have these health transfers, and they keep going up, but there's not a lot of accountability to those. And there's been more of late, which I think is helpful in the prioritizing certain areas like mental health as an example. But, we talk and we hear it's chronically underfunded, our healthcare system. Yet if we look at spending per GDP, it's I think it's still among one of the higher in the OECD countries and
yes, we
globally.
are slightly above average among OECD countries. It's not as if we are being
Right.
very cheap on share of GDP devoted to healthcare.
So the question is it the right spend at the right place,
Yes,
right?
of course.
And that's, I think, what we're getting to is that the traditional models of care are not able to keep pace with the demographic shift and where we're going.
Yep.
So
Yes.
that's why we need to rethink, transform what the definition of primary care is and give people more access and spend more wisely while we keep pace with inflation and everything else. So, I think pharmacare would be a perfect example. We've talked, about pharmacare, it seems like as long as I've been on the planet, and we so-called have pharmacare now, or will have it, but it's not really the true national pharmacare. It's two categories of drugs. The funding that's been allocated to that is not sufficient even for contraceptives and diabetic medication.
Yep.
So, is the government going to be able to federally create this whole infrastructure through their current institutions to be able to administer this? And I don't see that, but I do see, similar to the dental care program, the daycare program, bilateral agreements that fills the gaps of each province's patchwork system within their current systems. I don't think we have the luxury to be able to blow it all up and start over. And that's what it would need for the federal government to do it, right? And then you got the politics of that. So if it's a conservative government, like Alberta right now, they're not inclined to work with the federal government. So that's the complicated web, right?
Yep.
I guess I'll weigh in then. My goodness. Okay, did you say provincial or federal?
Are you talking
Well,
to me?
I think you can. There was a question about federal, and then there was a question also specifically about expanding NP-led clinics in BC. So you can respond to both, or do the federal piece, and then we can
Sure.
follow up on specifically NP clinics.
First, federally, right now, we're at a critical juncture right now. There's a Chief Nursing Officer of Canada, and that role is sentinel to actually include and continue to advocate and advise on matters for nursing and nurse practitioners. So I want to make sure that continues in that role as well. The Canada Health Act interpretation letter should be following shortly and including not just nurse practitioners and other healthcare providers right now. It doesn't compel, however, the provinces and territories to invest and fund in them. So some type of an accountability measure to incentivize it would be very, very helpful. If we're going to harmonize across Canada, there is, and data is compelling. They talk about a one identifier that will move forward, one regulation across, similar scope of practices, similar across Canada, for example, is very a reality in nurse practitioner landscape as well. We talked about BC and Alberta. Many of these things that are being initiated, we commend them. Again, though, they're pilot. We need to make sure that they're being set up for success right now, on top of ensuring no structural barriers are enacted or removed right now. Can you imagine what the landscape is like right now? There's some very, very collaborative areas that they don't have that overhead. We all have administrative burden as well. And more importantly, we do tend to take a lot of the patients that have been orphaned or unattached, or those that are not counted as primary, that those that have a primary care provider because they are not attached with data or even recognized. How we change our language is who's your primary care provider, who's your primary care professional, for example, right from an emergency across the health system. We ask who's your doctor versus who's your primary care provider. Tells very different things, so that they get copies of the report. Or, you know, when Jason mentioned, for example, they prescribe something and they ask the same thing, we communicate that as well. So that needs to happen, and dedicated funding and inclusion at the provincial table with many of our physician colleagues, and they have great influence and impact, and they're great thought leaders like many of us, but many times we don't negotiate with government on that. I think it's amplifying the power of the quads, the regulators, the educators. We haven't even talked about increasing enrollment in seats of nurse practitioners across there. That could be a really easy solution as well. So we need to think about how associations work together, and industry and our employers, or those that are self-employed as well.
Well, I was like, I will say, we are almost at time, but John's got his hand up, so I was like, I'll let you get one last word in, and I will reserve my quick download on arbitration and the difference between OHIP and the insurance versus scopes. And I'll just say I put the link to the paper that we did in terms of the subtle nuances between the public and private rules that exist across the country in the different space, sort of between these different policies. So I will just say the links are in the chat. John's paper is also there. And I will give you one last word there, John, and then I'll have to do a wrap up. I'll just say thanks to everyone for joining right now, and I'll do my final wrap up after your last point.
I don't want to be glib, but the last time that the provinces did think seriously about change was when we had this fiscal deficit across the country, which was very severe in the 1990s. Saskatchewan's a small place. I was part of the discussions of what we had to do. We closed 50 hospitals, which we should have done long before. Everybody knew that they could only provide minimal health care, but they were kept open in order to provide middle-class jobs. These are painful decisions to be made if you're going to do the kinds of change that we need to do now.
So it's going to take courage and political will, among
Yes.
other things.
Among other things, yes.
And so maybe that will be, I was like, that seems like a perfect point to wrap up on, is that we need courage and political will to do the things we know are in fact a good idea. And that actually, I'll just say thank you to everyone for joining us. Thank you to our esteemed panel, as well as Geneviève for the introductions and J&J for the sponsorship. And I will just highlight that if you enjoyed this conversation, please do check out our website and the papers I put in the chat, but also we have another webinar upcoming on Beyond Algorithms, AI Solutions for Canada's Healthcare Challenges on Thursday, November 28th. So we will certainly be continuing this healthcare change discussion, but this time we might be talking a little bit more about tech than about the providers. But let's face it, it's an all hands on deck problem. And so I'll just say thank you to our panelists. Thank you for joining today. And with that, you all are free to get back to your normal day-to-day office lives. And thank you for taking this break with us.
Thank you.
Thank you.
Glad
Great
to
job.
meet you virtually. I have to go on to another virtual meeting.
Take care,
Great
everyone.
job.
Bye-bye.